Good morning, good afternoon, and good evening, everyone. I'd like to welcome you all to this webinar. We're so excited to have you with us. My name is Erin Milkey, and I'm a Senior Family Planning Advisor at USAID and have helped manage our fistula programming for the last 13 years. Now we're so pleased to share this event with you towards a fistula-free future, 15 years of breakthroughs and program impact. The three sections of this event will discuss how access to quality fistula care has been transformed over the past 15 years. Second, the need to connect women to knowledge and care if we are to achieve the goal of eliminating fistula by 2030. And third, the contributions of many partners in cultivating and enabling environment to that end. Now, I'd like to introduce Kate Crawford, who will be giving us some opening remarks. Kate Crawford is the Director of USAID's Office of Maternal and Child Health and Nutrition and a Senior Foreign Service Officer. Over to you, Kate.
Hi, thank you, Erin. Thanks, everyone. Good morning, and thanks to EngenderHealth for inviting me here. I enjoyed the photo montage. It really took me back to some places. So I was on our emergency team during the Rwandan genocide and knew Panzi Hospital long before it became a center of excellence for fistula care. And I happened to be back there last year, about this time last year. And I can't tell you how, what admiration I have, obviously, for the folks at Panzi, but also for what EngenderHealth has done to help this project along, and the progress that has been made was really, really impressive. So on a personal note, that was just, that was a lot of fun and great to see the photos. So again, thank you, everybody. I'm not sure where everyone's joining us from. I think maybe from many parts of the world. So good morning, good afternoon, good evening. As we celebrate the close of the Fistula Care Plus project, it gives us a great opportunity, even if we're doing it virtually, to reflect on what has been for us now 15 years of fistula prevention and treatment care, and the many lessons that we learned through the Fistula Care Plus project. And then obviously to look ahead at how we can do it better, provide greater access and quality of care to women still suffering from fistula, and ensure that this devastating condition is no longer a threat to any women, to their health and well-being. High quality fistula services are not obviously just in the numbers of good surgeries, as important as that is to the individual, but it's really about building country capacity and promoting country-led integrated health systems services that support women's access to good prevention and good care, respectful care when they're in need. Over the past 7 years, the Fistula Care Plus has successfully addressed some of the greatest challenges, reaching women in poverty without access to voluntary family planning and quality childbirth services, providing sophisticated surgical repairs in hard to reach and very challenging environments, and expanding the evidence base in ways that have shifted the provision of quality care and integrated it more mainstream into maternal health services. I know 15 years ago, if my memory serves me, USAID was a bit hesitant to enter the fistula care space, but I think we have learned an incredible amount. We have learned how successful the partnerships have been, partnerships with agencies like EngenderHealth, UNFPA, national governments, community and faith-based organizations, professional and private sector organizations as well. And, you know, we can see that a fistula-free future for women everywhere is not impossible, and it really starts with strong country commitment. So with sustained bipartisan congressional support, we will continue our long-standing support for fistula prevention and repair, now through the new Momentum Safe Surgery and Family Planning and Obstetrics project, which was awarded last September. The expanded safe surgery focus of this project will continue the great work of the Fistula Care Plus, integrating fistula care into essential maternal health services, building obstetric care more broadly, enhancing public-private partnerships, mobilizing domestic resources and domestic commitment, and putting evidence-based policies into practice to support the health and well-being of mothers, their families, and their communities. So again, it's a real honor to be invited to help close out and celebrate the Fistula Care Plus project. I look forward, obviously, to the new work under Momentum. And before turning this over to our distinguished panelists, we do want to show you just a share. It's a very powerful example of what this kind of care, the difference this can make in a woman's life. And this is called Justine's story. So we're going to run this video and then turn to our panelists. So thank you again.
Nga sinakufuna obwo obulwadde bwa fistula naye sikiwuliranga era naye sikimanyi nti gye buli. Nali nzadde omwana addako kwoyo era eyabundeetera oba olunsi nembeera nga buli kadde nga mbeera mu mazzi mpunya. Okubeera nga ntambula mu bantu kyo kiswaza naye saawuliranga bulungi. Namala eyo bw'obulwadde namala nabwe emyaka 3. We yabangawo yabikolanga. Nazaalira ku Monica naye waliwo abasawo abayamba abakyala nga ggwe. Ekitovu kale bwe nalina fistula nga mpulira mu mutima gwe ndowooza ye tewona kubanga nali maze nakyo emyaka emingi kati ne bansiibula n'enkomawo ewaka. Waaliwo enjawulo ate ekirala kyembeebaza tebaakoma kukujjanjaba era nze nafuna embuzi okuva era ekitongole kyammwe eky'ekitovu. Esente wezikale embuzi ezo nzirunda kunnyambako ku bizibu ebisinga ebyewaka ne bansasulira naye nga mpola naye nga nkikola naye kati nkikola mpulira nyina amaanyi nga tewali kintu kyonna kintawaanya. N'okufuna ne wabaawo nti waliwo ababuyina waliwo obuyambi ku ddwaliro ne bafuna obuyambi. Wemba ngenze mu nkiiko z'ekyalo oba ku kyaki njogera ku bubi bw'endwadde ya fistula. Mbabuulira kwewala okuzaalira mu kyalo. Biri bulungi kubanga buli wentambula kati ndaba ngenda nkyuka ndi bulungi.
I'm always so inspired to see the words of Justine and to think about all the women who've had fistula care and then gone on to assist other women in their communities, both for prevention and treatment. And now I'd like to welcome and introduce all of our panelists. Oladosu Ojengbede is a professor of obstetrics and gynecology and director of the Center for Population and Reproductive Health at the College of Medicine, University College Hospital, Ibadan, Nigeria. Vandana Tripathi is the director of the Momentum Safe Surgery in Family Planning and Obstetrics project at EngenderHealth. Prior to this, she led the Fistula Care Plus project, including the development and implementation of the research and learning agenda. Karen Beatty is the ad interim director of the Fistula Care Plus project. Karen has been involved in EngenderHealth's work on fistula from its beginnings in 2002. I'll be asking each panelist some questions, but as we go along, we also invite everyone to add their questions in the chat box, and we'll have time to answer them after each of our panelists has presented. So starting with Karen, you joined the Fistula Care program over 15 years ago. What was the landscape like then, and what have been some of the achievements and highlights since?
Thank you, Erin. Greetings, everyone. It's so nice to see friends and colleagues from so many places. EngenderHealth's history with fistula goes back to our very early collaboration with UNFPA and the Women's Dignity Project almost 20 years ago to conduct the first needs assessments in 9 African countries. In each country, there were dedicated pioneer surgeons and some institutions providing treatment, but outside of those individuals and institutions was a different story. From the 9 country assessments, we found a lack of awareness of the causes, symptoms, and treatment options, many missed opportunities to prevent fistula or its recurrence, severely limited access to treatment, surgeons, bed space, and equipment, limited internationally available clinical or epidemiological data on which to standardize care, and few policies and strategies to address at the national level. So this slide summarizes the various projects and activities we've subsequently worked on, and EngenderHealth is grateful to USAID for its continued support over the past 15 years. In addition to our work on fistula, we were charged by USAID to gather data and share information with bilateral projects not supported under the global projects. Next slide, please. To address the challenges, we focused on the fistula care continuum: prevention, treatment, and reintegration. For prevention, increasing access to family planning, counseling, and services was a priority. We supported almost 2 million counseling sessions for family planning and provided contraception equaling almost 1 million couple years of protection. Interventions to address obstructed labor, the most frequent cause of fistula, were emphasized, including partograph use, C-section indication rates and practices, and improved use of catheterization for prevention. More recently, the association between self-reported fistula symptoms and gender-based violence were explored. Over the life of these projects, more than 1,100 facilities were supported for prevention services in 15 countries, and more than 64 million individuals have been reached through outreach and mass media. We developed many tools, job aids, and curricula to support this care. Next slide, please. To address the severely limited access to fistula care, we set about increasing the capacity to provide treatment. With our partners, usually senior expert surgeons in the individual countries, 394 surgeons were trained in fistula surgery, and more than 32,000 health clinicians received training in prevention and treatment related topics, including anesthesia, intraoperative, and postoperative care. More than 57,500 repairs were supported by USAID, both by EngenderHealth and its partners, and by USAID bilateral projects and their partners. Along the way, the evidence base to promote standardization of care was strengthened, and 2 examples are listed here. In collaboration with partner institutions in 7 countries and with WHO, a randomized trial was conducted to demonstrate that 7 days postoperative catheterization was not inferior to longer-term catheterization. This shift can enable facilities to serve more women and, most importantly, reduce the burden and discomfort of the post-operative period for women themselves. In collaboration with the Population Council and partners in 2 countries, research was conducted on barriers to treatment, which include long journeys to health facilities, limited decision-making, low literacy of community volunteers and women affected by fistula, and limited knowledge about capacity for treatment and stigma. Vandana will talk more about this research later. Next slide, please. Fistulas range in complexity from small, fresh fistula that can be treated with catheterization to extremely complex cases that require major surgical intervention, such as urinary diversion, bladder reconstruction, or other intervention. But across that spectrum, the outcomes of the 57,500 repairs I mentioned before are as shown on this slide. 77% were closed and continent, 10% were closed and remain with some incontinence, and 13% are not closed, most likely the more complex cases. Thank you.
It's really sort of amazing to think about how much has evolved and how much capacity has been built over time. So Professor Ojengbede, as an experienced surgeon and trainer, what have been some of the breakthroughs in capacity building and surgical quality that you have observed over the last 15 years?
Thank you, Erin. Karen just spoke about the 9-country assessment over 20 years in Africa. That assessment, some of the findings, one of the key findings was the severe limitations in access in all areas of input to fistula care. Access in terms of quality personnel, the nurses who are trained, there was severe limitations, who have been trained and are highly skilled to look after these patients. Even in infrastructural availability, and also in bed space. There were many patients, but the bed space was not there, as many of the facilities did not have the capacity to offer quality fistula care. Also, equipment and so many other inputs into ensuring that these women have access, immediate access, unhindered access to quality care. So obviously, there was an urgent need to develop a workforce to increase access to quality care, be it prevention and treatment. Shows a capacity building for obstetric first platform that was developed by USAID and EngenderHealth. And as you can see the slide, the plan lays out all the inputs such as planning, resources, and evaluation, support, and monitoring, which all input into ensuring there was competency-based training rather than theoretical, because fistula care is actually things of skills, And all these resources will lead to improved leadership, improved policies, and improved standards of care, such that there will be a strengthened training system, okay, and also more providers performing standard care, post-operative care, and follow up for rehabilitation and reintegration of these women, therefore leading to increased acceleration of clearing of backlog of cases, and also improving the capacity to prevent new cases of fistula forming. Next slide, please. Next slide. Now, this second slide is the template that was developed actually gave us a help to develop several tools and curricula which standardized and support the quality of training or the various cadre of professionals that are involved in fistula management and care, be it the doctors, the nurses, the social workers, and also the supporting staff. The summary of the tool is that there was an increased opportunity for in-country programs to have templates which they can use to develop quality training, expand the number of fistula personnel that are available in country, and have a standardized training mechanism which can be compared with all across facilities, across even countries globally. Let me take a time off to also talk about other tools that have been developed. EngenderHealth also developed and shared with us the Safe Surgery Toolkit. The Safe Surgery Toolkit we introduced in Ibadan in 2016-2017 in Nigeria, and we found that it was indeed very supportive in improving the quality of our training and quality of our care. And I have led some of my colleagues, senior ones, to teach and train perioperative nurses, surgeons, nurses on the clinical side on Safe Surgery Toolkit. The Safe Surgery Toolkit itself helps to amalgamate and embed the care that these women receive from the different categories of professionals that are involved, right from the time of consultation to the time of evaluation, even to time of investigations, preoperative preparation, even inside the operating OR room, and post-operative care, and indeed in rehabilitation and reintegration. Also, the Safe Surgery Toolkit helped to adequately, appropriately refer patients to where they can receive quality care. The Safe Surgery Toolkit promotes teamwork, okay, because all professionals are involved. It also ensures ethical consideration for these patients. It has helped clinical services to prevent mishaps in, for instance, treating one side of, a left ureter rather than treating the right ureter. It also has helped with documentation. We know documentation has been very poor. Data documentation has been very poor, but the Safe Surgery Toolkit has helped us to improve on that. It has also helped us because it has trackers that for monitoring outcome of care for patients, so that we can track the quality of our clinical services and see whether we're improving or not improving, and also track outcomes for the patient, whether the patient is healed, whether the hole is, the fistula is closed, but the incontinence persists, whether the patient requires further treatment, and so on. We also know that the Safety Surgery Toolkit also tracks the adverse events, which are often not mentioned in the patient's case file. There are other guidelines that have been developed with substantial input from EngenderHealth, especially with the federal government of Nigeria. We developed, for instance, the guideline and protocol for urethral catheterization as a means of preventing fistula, especially with patients who have prolonged obstructed labor, or even in managing simple cases, because simple cases that are timely provided with catheterization can heal, or even reducing the number of fistula, or reducing the size of the fistula. We have widely shared this amongst the partners of USAID Fistula Care projects across countries. And in Nigeria, we have trained all our fistula care centers in the use of urethral catheterization for the prevention and treatment of obstructive fistula. Recently, we have actually also had to add on WASH, even though it improves quality of care, it may not be directly for fistula care alone, But worse, because we know that infrastructure is very deficient. And so we also have added input to have adequate water supply and sanitation and so on and so forth. Thank you.
Thank you, Professor Ojengbede. And the government of Nigeria has certainly been a leader in the forefront of adopting some of these standardized guidelines and approaches to fistula care. So now I'd just like to remind people to put their questions into the chat box and we'll answer them later. And I'll go back to Karen to ask, what are some of the most critical lessons and trends that you think impacted the treatment and understanding of fistula care?
Thank you, Erin, and thank you, Professor Ojengbede. We couldn't expect to share all the lessons learned over the course of 15 years, so these are some selected lessons and trends. But as Kate mentioned earlier, the most important driver of the work we've done over these years that has impacted the treatment and understanding of fistula care is recognizing the importance and the value of partnership at all levels: international, country, regional, public, and private. Partnerships maximize coordination, contribute knowledge, and ensure that supported activities are informed by current evidence and current priorities. Over the past 15 years, EngenderHealth has collaborated with partners in 15 countries. USAID has also supported repairs in a 16th country, Tanzania. The asterisks on this slide indicate where there have been bilaterals, some managed by EngenderHealth and some managed by other partners. Partners in these countries have included national governments, civil society organizations, fistula treatment centers, hospitals, and communities. Next slide, please. At the international level, clearly funders, most notably USAID, have been critical to this work. All of these institutions have been essential to our collective ability to expand access to quality fistula care through surgery, through the development of tools, job aids, and curricula, through the development or implementation of a shared research agenda, and through dissemination of project and partner learning. Next slide, please. An international research advisory group was convened to identify priority research themes. 11 were identified, and Fistula Care Plus and its partners have advanced knowledge in 8 of those areas. Research consultations were held to develop specific research agendas and produce standalone reports, synthesizing current evidence and program needs. All of these reports are available on the website fistulacare.org. On March 22nd, in a couple of weeks, there will be a second end of project event to share the learnings from this research agenda in more depth, and we'll share more information about this event toward the end of the event today. Public-private partnerships are essential, and we have been fortunate to collaborate with these institutions, noted on the slide, to advance the quality of care through equipment provision and training. Next slide, please. Women often need to wait for the availability of a surgeon, operating theatre, or bed space because fistula is never viewed as an emergency. Some women may have waited years for surgery, but with the capacity building and expansion of access we've referenced before, it is becoming increasingly common for women to have access to routine care. It may not be on demand, but surgeries are scheduled routinely with more surgeons, more static facilities, and more frequent visits to rural areas by expert surgeons on a schedule. Fistula Care Plus annual reports reflect an increase in the use of the standardized tools and approaches to address the fistula continuum of care, some of which Professor Ojengbede just described. One of the early and ongoing challenges was the lack of a shared language to communicate and describe fistula and to serve as the basis for training. In partnership with the International Continence Society Standardization Committee, that's difficult to say, consensus-based definitions to support diagnosis and management of fistula have now been developed and shared. Improving documentation and measurement has been an ongoing quest and has included a technical consultation to examine measurement and estimation of fistula incidence, prevalence, and treatment backlog, a review of methods and tools used to identify fistula cases in research studies and surveys, the inclusion of fistula and pelvic organ prolapse in the development of the Bangladesh Maternal Mortality and Morbidity Survey, and subsequent technical assistance for a clinical validation study to evaluate the sensitivity and specificity of a questionnaire to screen for fistula and pelvic organ prolapse. And finally, Fistula Care standardized data collection across its supported activities and over time supported partners to improve and share national level documentation and measurement, including health management information system improvements. Thank you.
Thank you, Karen. And I'm just being reminded of what a steep learning curve I had when I entered into this area of work. And it's really sort of amazing to step back and think about this evolution and including just this coming up with standardized terms. You know, there were so many experts around the world working in fistula, but not as much shared information and terminology and so many other resources that have evolved over time. So now I'd like to ask Vandana, how did the research, standardization, and training translate to care in communities?
Thanks, Erin. Thanks, there's a slide. The program learning and research that our partners and the project have conducted have taught us a lot about how to improve and standardize care in communities. First, that fistula care isn't just repairing the hole. It's not just the surgery. From physiotherapists, which you see here, who've worked with project-supported surgeons in the Democratic Republic of Congo, we've seen the profound impact that standardized physical therapy can have for women, supporting their healing and their recovery after surgery. From research we were able to do with the Demographic and Health Survey program, we've also understood that women reporting fistula symptoms are also much more likely to report physical and sexual violence. So this means that positive, healthy reintegration may not always mean a simple return to the relationship or the family structure that a woman was in. Screening for gender-based violence, referral for GBV services has to be integrated into fistula care. We've also learned that repair isn't the only way that women with fistula can be supported. Through research that was led by our Ugandan partner, Terawode, we learned that customized psychosocial support, so peer counseling, skills education, other social services, can dramatically improve quality of life for women whose fistula has been deemed incurable. So even when fistula care can't include repair, and women have to live with that incontinence and the other consequences of fistula, well-structured interventions can actually reduce depression and can help women live with dignity and empowerment. Similarly, we've learned that we can also support and monitor women's reintegration and their well-being after repair in a holistic way. The project was really proud to work with colleagues at UCSF and Makerere University to develop and validate the first tools to support standardized measurement of women's trajectories, their well-being after repair. And this isn't just academic information, this can be used to guide the services that fistula treatment sites provide, and also the services that community-based partners like Terawode can provide. Finally, learning through this project has also, I think, helped us make and recognize a profound shift that's needed, a shift in orientation that's needed if we're actually going to eliminate fistula in the next decade, which is what the global community has pledged to do. Eliminating fistula, of course, means treating existing cases, but it also means preventing new ones. Next slide, please. The standardized data collection and monitoring that we introduced through Fistula Care Plus, and of course that's happened in parallel with really important improvements in HMIS data collection on fistula in many countries. It's confirmed what researchers have been calling attention to as well. More and more fistula is caused by unsafe surgery. In sub-Saharan Africa, it's most often a cesarean. In South Asia, we also see hysterectomy contributing to this. So what it means is that if we only focus on repairing existing fistulas, we're not even treading water, let alone progressing towards elimination. So we'll see we would see a huge burden of fistula for years to come if we can't help make surgery safer. So a huge learning from this project is that we, meaning health systems, meaning development partners, everybody engaged in maternal health and fistula, we need to track the causes of fistula systematically and use this information to target support so that health systems have the capacity to provide these essential obstetric surgeries safely. Preventing new cases also means supporting women who've had fistula with family planning, counseling, and services. Research we supported in Guinea showed us that there was significant fistula recurrence, often related to unintended pregnancy. So can you imagine going through the ordeal of a difficult delivery, probably losing your baby, developing a fistula, finally reaching care, and then only to see that happen all over again? So holistic fistula care isn't just the surgery, it's that direct referral and support for family planning and for skilled care, including safe cesarean if needed in future pregnancies. So our work in Uganda, in Nigeria, and other settings has shown how integrated training of fistula providers can help strengthen family planning counseling and referral at fistula treatment sites. So the shift to a prevention mindset, whether it's the family planning side or it's the safe surgery side, is one of the biggest lessons that we're hoping to take forward in future initiatives, including the new USAID Momentum Safe Surgery in Family Planning and Obstetrics project that was mentioned earlier. As Karen Beatty mentioned, we will have a second Fistula Care Plus end of project event on March 22nd, and we'll dive deeper into some of these learnings and tools, and also brainstorm the next wave of research, the priorities in preventing and treating fistula. And so we really hope that many of today's attendees can join. Thanks, Erin.
Great, thank you, Vandana. And now our next speaker is joining via video. Dr. Kenny Raha Muroi is an OBGYN and obstetric and traumatic fistula surgeon in the Democratic Republic of Congo. Dr. Muroi will speak to us about the personal impact of training and capacity building and of being able to provide quality fistula care to clients.
My name is Kenny Raha Muroi. I am an OBGYN and obstetric and traumatic fistula surgeon. I am working at Panzi Hospital in the DRC, the Democratic Republic of Congo, for 14 years with Professor Dennis. In addition, I am a teacher at Université Évangélique en Afrique, where I train young doctors for good obstetrical and surgical practice. Beyond all this, I like scientific research, which I believe is a way to make a difference. In my career as a fistula surgeon, one thing has most impact on me. It is the smile and the joy that we bring to women who live with obstetric fistula. When we meet with them, they express the pain of years of inaccessibility of specialized fistula care, especially in our country. But once they are operated within 2 weeks spent with us, the myth about fistula is shattered. They recover normal life. It's true that fistula surgery is often challenging when you spend hours fixing a fistula. All this time is wiped off by the joy and the smile of these operated patients. Despite the work done by Fistula Care Plus, there remain priorities for fistula care in the future, including capacity building for fistula prevention in DRC, where maternal health indicators are still not good, building capacity for treatment and reintegration. Thank you for all, and congratulations.
Very inspiring. So I'll turn now back to Professor Ojengbede to ask, as a national and international leader in fistula care, what have been some of the breakthroughs and impacts of policies around fistula care, and how has that affected implementation?
Okay, thank you, Eric. Now to put my response in perspective, I would like to use my country, Nigeria, as an example to show some of the benefits that have accrued to the partnership between EngenderHealth and the various countries. Now we are partnered with USAID, UNFPA, and EngenderHealth, both before and after the Fistula Care project. And we have evidence, that, at least an assessment, that in Nigeria, we have about 150,000 cases, women who are waiting for repair who have sustained injury. And we also have an estimate of about 12,000 new cases every year. Now, if you put all that in perspective, especially knowing that we still do not repair more than like 5,000 per annum, even if no new cases exist anymore, the old cases will still take us 83 years thereabouts to clear them. So obviously, there's a need to do far more than we were doing. Now, Karen made reference to the year 2002 assessment by EngenderHealth and UNFPA in Nigeria. And following the results and reports of that assessment, the federal government of Nigeria decided that fistula should now be made as part of a comprehensive SRH program in the country. And that led us in Nigeria to form the National Task Force of Fistula, and also for the federal government to establish a specific desk to address the various challenges surrounding fistula in Nigeria. So the country established the fistula desk at the Federal Ministry of Health. And since that time, following that assessment, in 2005, we developed a national strategic framework and plan, which was to cover year 2005 to 2011 to 2010, 5 years. And after that, we follow on with a one that covered 2011 to 2015. And since then, we have developed a third one, which is currently on and covers into 2023. Now, I'm going to focus my subsequent response on this last one. And you can see from this slide, that strategic framework, which was supported, the development was supported by EngenderHealth, has as its goal a 30% reduction in the incidence of obstetric fistula, a 30% reduction in prevalence, the existing cases, and beyond just preventing and repairing, a 30% increase in the number of women that are treated that are also socially rehabilitated and economically empowered. Because we realize that, in fact, to make it comprehensive, fistula effect of fistula on quality of life does not just end once the hole is closed and the woman becomes continent. And as you can also see from the slide, the current one has 7 priority areas, which includes prevention, treatment, rehabilitation, like I just said, communication, that is community mobilization, talking to the people, talking to the society, addressing the same traditional practices that had led to the cause of the fistula. And also, Dr. Kenny from DCR did say he's interested in research, and we knew that there was need to do some research, both basic and implementation research. And of course, we now included leadership and governance, as well as monitoring and evaluation. As you can see, this framework has been costed And that means at least the government can begin to address it by budgeting money nationally and not leaving to development partners alone to bring the money to prevent or treat cases of fistula in Nigeria. Now, can I go to the second slide, please? Second slide, next slide. So what are the impact of these strategic frameworks and plans that we have developed? And the first one is that the Federal Ministry of Health, like I said, has included a specific budget line for fistula. Before, fistula had no budget line at all. And in fact, all reproductive issues, mobilities were just embedded under reproductive health. And what that meant was that some will get more money than the others. Like fistula, which had little importance, focus on it, was not getting much. And so the federal government nationally has separated a budget line for fistula, which is dedicated for prevention, treatment, and rehabilitation of cases. Many states also have followed suit, and most of the states, the 36 states and the Federal Capital Territory, also have dedicated fistula desks at the state level, at the primary care level, and also have budgetary allocations to address within the states the issue of fistula. Now, you can see that the strategy is now costed, and that means that we can begin to know what the challenge, how much the government should actually vote for fistula. Not just voting a meager, a token money for fistula, but to see what will be required, and for the government to respond, and for the partners also to support the government in also voting some money for fistula care. We have been able to increase access to emergency obstetric care. For instance, not only has emergency obstetric care been strengthened under safe motherhood, all the fistula centers in the country provide and offer free C-sections for all the patients that have had fistula previously and are pregnant, and for those who may also require emergency obstetric care, but who cannot get access to it from other public health facilities. The fistula centers that have been established have been mandated to offer free fistula cesarean section services. Currently now, we've developed protocols for catheterization, which I mentioned earlier in my speech. And we have shared this on to other countries. I've trained people in South Sudan, in Liberia, and also they are implementing catheterization as a preventive and treatment measure. Now we have in the country 19 fistula centers, and 3 of these are centers of excellence for fistula, especially for very difficult cases, the cases that are deemed to be irreparable. And the target of the government is actually to have one of such centers of excellence in each geopolitical region of the country, and we have 6 of them. Currently, we have 3 of such centers, through which many surgeons have been trained for the states and for public and private sector, and also other professionals have been trained, including nurses, including those who rehabilitate social services, and also other professional anesthetists and so on that are involved in fistula care. We have also had to, this was also during the EngenderHealth program, Fistula Care Plus in Nigeria, do the unlocking of potentials from between private facilities and public facilities that have skilled manpower in teaching hospitals, but where fees were charged and the patients are not able to access care. We now partner such facility, teaching hospital at the federal level, with facilities at the state level, which offer free services but do not have the skills. So it's like, a partner, we cross over, that the skills in the teaching hospitals are made to bear on the services provided at the state level by training doctors for the state Ministry of Health, and by, in fact, the skilled manpower in the teaching hospitals also going to those state facilities to conduct training, to conduct service provision as well. Free services are expanding, like I said. We also have used the pooled efforts, which is a mechanism by which many cases are cleared out of the cases that are awaiting service by bringing experts to an area of high turnover cases and making sure that such are pulled together. The experts come in, they clear all the backlog, and they use the occasion also to train the local doctors and also to mentor them. Skill cast position has been embedded into what we do, because most of the patients now, after successful treatment, one of the challenges is that they now have to go back to the same social environment that initially, engendered the fistula itself. So now we increase in training them in skill acquisition, and the government gives them loans, seed loans, to start off a business which can sustain them economically, and they don't have to develop on husbands or relations who are themselves poor to be able to access services. Nigeria's vision is to be fistula-free by year 2030, and we hope that what we are doing currently will take us there. However, like I said, with 150,000 waiting cases, we may need over 33 years to be able to clear the backlog. So therefore, the challenges that still remain include that we have still a large backlog. We have fragmentation across states and partners with different models, with different ideas and things they want to do. And the cost of the treatments is quite enormous for fistula care. We need to engage fully with states to work together. There is improvement in data collection and right now. And so even though we don't have a national data yet, but at least we have regional data, especially at the centers of excellence, where training and research conducted, and we're expanding that to all the general hospitals, the district hospitals, which do not have capacity for rigorous research. Yeah, I think that what we have done so far is to have catch on the input from EngenderHealth to adapt what has been developed to local circumstances and situations to improve the quality of care and access to care for women who have survived prolonged obstructed labor. Thank you.
Wow, thank you for this real overview of all of the changes, especially the government has made over time, the evolution of its strategy and the budgeting specifically for fistula, the health management information systems, and still more work to be done for sure. And you touched on an issue that I think is really important, and I know we'll hear more from Vandana on this, but to do with backlog. And clearly Nigeria still has a big backlog, but I know over the years, we've heard so much about backlog of fistula patients, but over time, really, I think with a lot of these concentrated efforts in many countries, slowly we're hearing that the backlog is reducing, and we may have to try harder to find more isolated patients, but in general now we're just seeing more fresh fistula and fewer women are waiting for decades and decades to get repair. So with that, let me turn to Vandana and ask, what role has community engagement played in fistula elimination?
Thanks so much, Erin. And women with fistula are in the community, right? And that's where we have to connect them to care. That's where the beginning is of reaching fistula treatment. At the start of this project, Fistula Care Plus, as you said about the backlog, we looked at estimates of how many repairs happen every year, and then estimates of how many women are living with fistula. It was clear that there's a big gap, and that there were a lot of women who hadn't been reached by existing case finding and outreach strategies. So through partnership with global organizations like the Population Council, VIAMO, and very importantly, community-based organizations in Bangladesh, in Nigeria, in Uganda, we've tried to identify and test and integrate new ways of reaching women with fistula who might not even know, I think as Justine said in talking about her experience, they might not even know it has a name, let alone a cure. So the key here is delivering information to women through multiple means so that everyone is reached and nobody falls through the cracks. The graphic you see here was developed by colleagues at the Population Council, and the point was to show the many steps that women have to take as they seek and before they reach and receive fistula treatment. And project research in Nigeria and in Uganda showed us how many barriers can stand between women and fistula care, whether it's stigma that makes it impossible for women to come to the community events where we were hoping they were hearing information about treatment, or the fact that even primary care providers might not know the treatment is available, or there's just the significant costs of traveling to care from a village. In this project, we've seen that innovations such as free fistula screening and referral hotlines using interactive voice response can cut through these barriers. Next slide, please. In Nigeria and Uganda, these types of hotlines, which you see some images of advertising here, helped. The hotlines paired with follow-up from community volunteers helped us connect hundreds of women with fistula to treatment for the very first time. In Bangladesh, we partnered with BRAC, which is the largest non-governmental organization in the world still, I think, to bring fistula information and screening right to women's doors. BRAC's volunteers used a simple 4-question screening checklist, which you see on the left here, to identify women with fistula symptoms and link them to community-based diagnostic events, bringing quality and standardized screening and diagnosis to very rural areas. This approach is actually now being replicated in Niger through the community-based organization Songe. So fistula care itself might involve specialized surgery that's delivered in high-level facilities, but that first step to getting there happens in the community. And we've seen that information and access can be amplified enormously if community-based organizations and primary healthcare systems integrate fistula and screening and referral into the work that they're already doing, versus it being something that stands apart and away from other kinds of health education and mobilization. Thanks.
Great, thank you. And I know we've had a lot of great questions come in through the chat box. I really appreciate that. So I just want to thank all of our panelists, and we will now take questions from attendees. I am getting some assistance from some behind the scenes folks who are helping to organize the questions. So let me just turn this first question about how does fistula care feature in universal health coverage? Let me pose that to Karen and to Vandana.
Sorry, had to unmute myself. That's a tough question to ask, but I think that one of the issues is that there are a multitude of plans at the national level seeking to all kind of feed into universal health care. For sure, one of the factors is the integration of fistula activities into a broader maternal, neonatal, and child health agenda, which then also feeds up into maternal health care. I'll pass it back to Vandana.
Thanks, Karen. I think that this is a really important question, and I think that it's useful to think about a number of issues in this way, linking them back to universal health care, because fistula can come across as a niche issue, right? It's rare, thank goodness it's rare. It maybe doesn't affect as many people as some of the other things that we talk about more commonly, But if we want to achieve universal healthcare, fistula and issues like fistula become really important sentinel indicators, because so many things have to go wrong from the community to the hospital for a woman to get a fistula. And so many things have to go right for that same woman to be found, to be reached, and to be connected to care, that I think the incidence of fistula, the length of time a woman lives with it, is a really powerful measure of progress towards UHC. And in particular, progress towards universal access to skilled care and to safe surgery. So I really, I think, advocate for us to look for issues like this as our, the canary in the coal mine, as those indicators that show us, are we getting there? Are we falling behind? And I think, are we getting there equitably? So I'll stop there. I know we have a lot of other questions. Thank you for that.
Thank you. And this next question will go to Professor Ojengbede and to Vandana, and it comes from Dr. Adamu Isa in Nigeria. The guidelines for urethral catheterization is indeed a great tool that can lead to major breakthroughs at the primary health care level. Does EngenderHealth plan to support a wider dissemination of the document at PHC levels in countries such as Nigeria?
I'm not seeing Prof. If he's able to answer first about Nigeria specifically, since that's where Dr. Adamu is, and then I can join in.
Hi, it seems that there may be a little technical difficulty from his end. So if somebody else would like to answer or take a different question until he's able to rejoin.
Happy to. Oh, there he is.
He has rejoined.
Maybe let's have Vandana.
Yeah, I was going to say, we can repeat the question as well in case Professor wasn't able to hear it. The question was the urethral catheterization guidelines that you talked about in your presentation. What is EngenderHealth or what are others doing to disseminate those guidelines to primary healthcare centers so that they're getting to the places, the maternity units, the places where they can be used for prevention? So I thought you could talk about Nigeria first, and then I can talk about how EngenderHealth may do that elsewhere.
Oh, you need to unmute.
Yeah, sorry. So after we start on to do the protocol, of course, the next thing will be to test the validity and to see whether it works or not, because that protocol was essentially based on experience of very, very senior surgeons, because nobody had ever written anything about it. And so we tried to put it on in like an implementation research. Does it work? What's the efficacy? What's the safety? Is it possible to do it? Is it doable? And now what we did in Nigeria was to train the midwives at lower level of care, at primary health care, to see how they can efficiently and safely implement catheterization as a preventive measure. So that is in place, because it's not always right to assume that every doctor and every midwife can safely insert a catheter. Actually, we've seen cases where trauma was inflicted on the patient. So that is one. And then two is to ensure that even the catheter itself is made available at the facilities, because most of the facilities don't have this implement. They don't have all the consumables. And like I said, for a follow-on on these cases and to link them with referral, because not all cases that are treated with catheterization will eventually heal. We pray that all should, but not all. And therefore, there should be someone who can have an oversight for the primary care workers, and also for a referral channel to be established, so that those that fail can be referred to where appropriate services can be provided.
Thanks, Professor. And building on that, EngenderHealth has supported the translation of these guidelines into French, into Portuguese, and they've been shared with other countries, for example, the Democratic Republic of Congo, Mozambique, and we've been supporting the ministries of health there to say, how do we want to use these? Do we want to adapt them? Do we want to adopt them? And one thing I'll note is we did a global survey of midwives, of skilled birth attendants, mostly midwives, to understand, do they feel, as you were saying, do they feel confident doing this? Do they feel like they believe, do they feel that it's important, that it works, they can do it, they have the skills? And one of the most important gaps that we were seeing was clear guidelines that empower them to do it. Supplies, knowing that the supplies will be there, not just the catheter itself, but the lubricant to make the insertion easier. So what we're hoping to do through the follow-on opportunities that we have is just what you're talking about: the guideline work, the policy work, the training, the support, and very importantly, the supervision and referrals, so that if it doesn't work to prevent a fistula, that woman doesn't just go home. She's immediately referred to a place where she can get help. So thanks for that question.
Great, thank you. So we've gotten several questions related to reintegration and provision of holistic care for women with fistula. And this one again will go to Vandana and Professor Ojengbede. The question is, overall, what do we know about how many women have received care from the social service net as part of reintegration post-repair? And what kinds of psychological, emotional support programs are integrated into fistula care?
Professor, do you want to talk about what happens at your hospital and what you see happening in Nigeria? And then maybe I can generalize from that. You're muted.
You're still on mute.
Yeah, the question again, sorry, about the role of integration and rehabilitation. You see, this is something that has now actually been studied very well. And the implementation has varied from place to place. We have yet to be certain to document exactly what determines the need for rehabilitation and reintegration. Who requires it, and we did a study, and many patients in some places, in the southern part of Nigeria, where education is higher, say that what they need best is the social integration, not even the economic, because many of them have not lost their jobs, and so many of them have not lost their marriage. Their marriage is still intact, it's still stable. Although in some other parts, this is not the situation. So we need, one is that we need to make it individualized, to make it contextual in the context where the facilities, not necessarily in the country, because the need for and the type of reintegration and reintegration in Nigeria varies from place to place. Even within the same region, varies from facility to facility. And we know that there are many factors that affect the need for reintegration and rehabilitation. The practice of where you kind of decide for each client what they should do as a means of economic development should be reconsidered. I think we should help them with what they know they want to do themselves, what they are capable of doing, what they can achieve, and be able to be independent economically. So I would say that we still need to study more on what the factors are that guide the need for rehabilitation and reintegration, what type of reintegration is necessary, and what are the potentials of each of the clients themselves in aiding in supporting the process of rehabilitating them, okay? I had a student from Uganda who did a study at University of Ibadan, and she did on reintegration and rehabilitation. There are 6 publications on that, which are very illuminating indeed, on what are the content, what are the factors that guide and inform the process of reintegration and rehabilitation.
Thanks, Prof. That was such a comprehensive response that I only want to add 2 things. One of the questions was really about measurement and tracking how many women receive this. And I think in Fistula Care and Fistula Care Plus, so many pieces of what's helpful were identified, whether it's having partners at the hospital for counseling and for discussion before discharge, physical therapy, support with a peer counselor you can talk to. And one of the challenges is a woman might not necessarily know everything that would support her right at discharge, right? Some of those needs might emerge after she returns to her community. Some of the long-term impacts that the need for follow-up support to get family planning. So I think one of the things we've learned is the importance of maintaining follow-up with patients, and what I hope we can do as we think about fistula care in the future is how can we use low-cost digital health, other ways to stay connected with women, to actually assess their needs, connect them to services, and to answer this question, to be able to answer it, to really measure what are the services women take, use, find useful, what are the ones that are not actually all that useful, and to use that to shape a more standardized. But as Professor said, it's standardized does not mean one size fits all. It's always going to have to be very individualized as well.
Thank you both for those answers. And it speaks to me also about the role of the partnerships and the different sources of support that women who are treated for fistula then can turn to for different types of support based on their individual needs. So this next question goes to Karen and Vandana. Can you talk about the balance of funding and program focus on treatment versus prevention?
I'm afraid I would have to go back to the budgets in order to look at that and be able to say something specific about that. You know, presumably there are individual objectives of the project and we could probably look at it, but there's also a lot of overlap. So when we're training about treatment, we're also training about prevention. So I think I don't have the specific answer right now, but we can certainly look at it. Vandana?
Sure, and I would just add, as Erin, as you know well, you know, we've had a theoretical split of something like 2/3 of the funding being from the treatment and care side, and around 1/3 being for the prevention side. But that metric it's been different in different countries. It's been different in places where the cost of care may have to include the cost of finding someone in a very rural area and getting services to people in outreach models, which bring other costs. I think though, as I was saying about just needing to shift our outlook to prevention, it's just incredibly important to recognize that they go hand in hand. You know, a woman who's been treated can have a fistula again. A woman who receives adequate prevention services may never need that type of service. So it's important to not see them as, I guess, you know, opposed or oppositional. They really reinforce each other.
Thank you. There's definitely some overlap. You know, we've definitely, in general, applied 70% maternal health funding, 30% family planning funding. And within family planning, that's all preventive. But additionally, some of the maternal health, you know, strengthening obstetric care is preventive. So yeah, it's not an exact rule across the board in every country. So this next question, I'll start with Professor Ojengbede and then see if Vandana or Karen also would like to chime in. The question is, can you talk about the composition of maternal health teams? Should these include staff that are specifically engaged with fistula care? How do maternity staff and fistula staff currently interact? Are they trained together? And sorry, you're on mute.
In most parts of the world where fistula is prevalent, most of the midwives are expected to be multitasking, okay? Because apart from, there's none of those countries that have enough midwives or enough doctors to provide quality care for every woman that is supposed to access such care. So I believe that there's a crossover between training for fistula care and for maternal health, because the emergency obstetric care looks after the woman, look after the baby, and ensures in preventing morbidity, including fistula itself. So midwives who are trained to provide quality care, safe delivery, apart from conducting safe delivery, are also at the same time preventing fistula. For women, midwives who, for instance, are able to do catheterization, they minimize the damage done with prolonged obstructed labor. So what we do is that we usually expect that those who are going to be trained as for fistula, either nursing or doctors, are those who have actually had some measure of experience in emergency obstetric care. Because you can't separate prevention and treatment of obstetric care. You can't totally separate the two of them. Okay, they are not mutually exclusive, as it were. So we train people together with doctors as team, doctor-nurse team from each facility on fistula care amongst member staffs that are already providing maternal and newborn health services in that facility. Okay.
Vandana or Karen, do you want to add anything to that?
I think that was as concise and thorough as anything we could add. Thank you for that, Professor.
Okay, so our next question goes to all of you. Maybe I'll start with Professor Ojengbade again. But how have we adapted to serve women with fistula during the COVID-19 pandemic? And this comes from Maria Dieter from the Momentum Knowledge Accelerator Project. So Professor, if you can unmute yourself, we'd love to hear. You're still on mute. You're still on mute.
Very great question, I said. Yeah. The COVID-19 has really negatively impacted on maternal newborn health services. Not only are women not able to access the service they need to ensure safe sexual and reproductive health services, the care providers themselves are worried, are concerned about their own safety, okay, in not being infected with COVID-19. And many of them also therefore stay back rather than be more proactive when the PPEs are not, readily available for them to use. That is in terms of prevention. For treatment, let me just give this example. In December, we had a camp. That was towards the end of the first wave. We had a camp in Ibadan, and we were hoping to just do about 15 5 days. But we had almost 150 women turned up. So we then said, oh, then we finished this, and we were able to do, I think, 78 in those 5 days. We double up. But still, we had so many. And we were planning, as we promised them, to bring them back after a 2 weeks rest. And then the second wave started. And we are yet to call them back. Very disappointing. Very disappointing because some of them voiced it that, oh, no, you are sending us away, you are not going to call us back. And now it has happened due to COVID-19. So I think it has affected it. And we just have to find a way of improving our preventive measures for COVID-19 and ensuring that the patients do not suffer because they are seen as cold cases. They are not, fistula is not seen as a very urgent issue to be attended to, nor is even rated as important like many of the other morbidities that women face.
I would just add to that we've certainly seen some of the same issues in a number of countries where even where fistula repair centers have stayed open, women have had a lot of fear of traveling, right? Taking any kind of crowded transport, a reasonable fear of what it might take to get to care. So we've certainly seen reduced numbers, reduced numbers of women coming. I've been astounded by the commitment of the providers, though. I mean, to keep working in very challenging conditions, to keep working at personal risk. And we know many clinicians have, of course, been sick, have been infected, and have even passed away. But what we've seen is like there's a continuity of care, and as Professor was saying, the demand increases and then it decreases depending on the kind of height of the infection wave. I think two things that are mitigating strategies. One is as Professor is saying, if you have to wait longer because it's not an emergency, to think about dignity kits, for instance, right? Supplies, commodities that can be distributed to women where they are, so that the waiting can be less awful. And the other is, and I think a lot of family planning services are doing this, all kinds of healthcare, where the degree to which some of the pre-screening, some of the counseling, some of the assessment can happen remotely through telemedicine, through digital health, then can reduce the amount of time that the woman might be waiting or in a crowded setting when she does finally get to treatment. That I think everybody has learned a lot about how to adapt. But the crucial difference is, because it is not an emergency surgery, there is this sense that women can and should wait until it's safer for them.
Thank you both. So I just want to say there have been so many great questions in the chat, and I'm sorry that we don't have time to answer each of them, but I'd like to give the panelists each a chance to share their parting thoughts on the following. What do you see as the top priorities for research, programming, and policy in the provision of fistula care from now to 2030? So let's go, Professor Jengbede, Vandana, and Karen.
Yes, if I refer back to the Nigerian strategy framework, which I contributed to, obviously, women need to have a right to safe delivery. Women need to, that should be not negotiable in all the countries. In Nigeria, I tried to do a calculation of how much it will cost the government to provide free emergency obstetric care services for women when prolonged obstructed labor, not just free service for delivery, for prolonged obstructed labor alone. It's nothing. It's not up to 1 day's sale of crude oil from Nigeria. And I think that women deserve to have the one day earning devoted for their health and safety, in ensuring that one, access to safe delivery is made available, not negotiable. All patients who have had fistula have access to it, and therefore we need to expand the facilities available and the skill sets. We need to upgrade it so that women, there's some women who have had fistula, because it's complex, they've just been going from place to place to place. They spent all their money, they've sold everything. So I think we need to make provision for those women, and we need to generally ensure that rights of women in the social setting, in developmental setting, including education, as in my culture, for instance, that it's not only the boy. Even sometimes a girl is more brilliant than the boy, they send the boy to school and leave the girl. Things that should be reversed, and the community should be mobilized to change culture. Culture is dynamic. And I think with that, we will move, accelerate, and of course, developing new technology-based systems of prevention and treatment, I think is important as well. Thank you.
Thank you, Professor. I think you talked about one of the cross-cutting things, right, about gender and culture, right? That if we're going, women have to be empowered, and cultures and systems and societies have to support women to fulfill their rights to information and to healthcare. If I think more narrowly about fistula, I think it's two things. It's prevention and it's integration. So by integration, I mean that every midwife is prepared to catheterize, right, after prolonged and obstructed labor. That every community-based organization that is talking to a woman about reproductive health or maternal health asks about incontinence. That no woman gets a postnatal care visit where there isn't a question about symptoms that might indicate fistula or other adverse consequences of complicated labor, right? So it's about continuing to integrate fistula information and screening into all of the places that already exist to provide care. So it doesn't have to be this constant standalone campaign-based approach. And then prevention. We know the volume of surgeries is increasing so fast. So much of it is life-saving and needed, but that surgery has to be safe. So just looking to the future and looking to eliminating fistula, we need to know that no woman is ever spending in a social capital, real money, going through who knows what to get to skilled care and then walking out with something like fistula. So I'll stop there, the prevention and the integration.
So not much to add to those excellent thoughts, but I do think that one of the challenges that we have experienced throughout has been the issue of women deemed incurable. And what are the needs and what are the opportunities for providing support and care to those women who remain incontinent, who remain with these challenges on a daily basis. So I think that's the one thing that I would add to what Professor Jengbade and Vandana have said.
Great, thank you all. Really, many thanks to our panelists. And now I'd like to introduce Tracy Baird for some closing remarks. Tracy Baird is the president and CEO of EngenderHealth. She is an experienced and respected leader in the women's health and sexual and reproductive rights field. Over to you, Tracy.
Thank you so much, Erin, and thank you to all of our speakers. I'm really proud that EngenderHealth has been a partner in the global effort to address fistula for the past 20 years. We really are working hard with many of you toward a gender equal world where all people can achieve their sexual and reproductive health and rights. And addressing fistula and other entrenched issues in maternal health is a key part of that goal. Until all women have access to family planning, antenatal care, safe delivery, safe surgery, and fistula treatment when needed, women will not be able to participate as full and equal members of society. So on behalf of EngenderHealth, I appreciate the leadership of USAID and the participation of partners around the world, including those on today's webinar. It's a pleasure to work together to restore women's health and dignity, to bring the smiles and joy to women that Dr. Kenny Rahamioi of Panzi Hospital mentioned in his video remarks, and for us all to work together for a fistula-free world. Thanks very much, and I'll pass it back to you, Erin.
We hope that today's presentations and discussions have demonstrated why USAID has invested in fistula programming over the past 15 years, as well as describing the way forward. We are proud to have supported over 56,000 surgical fistula repairs in Africa and Asia, and to have partnered with so many ministries, providers, and civil society organizations around the world to advance fistula prevention and care. Especially when we consider the crucial role of safe surgical care in preventing both obstetric and iatrogenic fistula, we are excited that the new Momentum Safe Surgery and Family Planning and Obstetrics project, primed by EngenderHealth, will support countries to implement their strategies for strengthening safe, indicated cesarean services, as well as expanding access to fistula care and the voluntary family planning services that are essential to fistula prevention. In addition to the capacity building and system strengthening work you have heard about today, the Fistula Care Plus project also developed and implemented an ambitious global learning agenda responding to gaps in evidence in fistula prevention and care. A second Fistula Care Plus end of project event on March 22nd will focus on the knowledge built and disseminated through the project, as well as the remaining needs for research and learning to advance fistula eradication. We hope you will join us for that as well. Thank you all for joining us today. And this is now the end of the event. Thanks and goodbye.